Hi, my name is Jānis Slezins. I'm board certified neurosurgeon practicing in Riga, Latvia, and today I want to share with you one of the interesting and complicated case which we are going to operate tomorrow. So this is 65-year-old female, previously quite fit and well, from past medical history, only hypertension, and she's taking antihypertensive medication for this. Other than that, no specific symptoms or diseases. She started to feel some symptoms about 4 years ago. So she started to experience some kind of cranio-spinal junction pain while she was turning her head on to the left side, and pain disappeared while she was straightening up the head. So she didn't pay too much attention to these symptoms for about 3 years, but over the last 1 year, the symptoms have become quite severe. She had an MRI scan with contrast, which I want to show and discuss with you, which explains her symptoms. And we are going to operate this case tomorrow, so let's have a look. So this is contrast enhanced MRI scan, sagittal view, so-called sagittal view, which means that we are kind of looking at the patient from the side. So there we can imagine that this patient has been cut in the middle, and we are observing her from the side. So there is an occiput here, this is face, not visible here. We can see some content of the cranium, so this is large hemispheres, these are cerebellum, this is a midbrain, and there is a spinal cord here. The border between cranial cavity and spine is somewhere around here, and you can see it's just behind this border there is some kind of well bordered, homogeneous, whitish structure. As we know, this is a contrast enhanced scan, and we already know that that is some kind of tumor that is collecting the contrast media. So we can play these images and see deeper or more to the surface, and we can appreciate this lesion. So now we know where it is, we want to see it better. So we are taking this so-called coronal cut. So we can imagine that patient is staying in front of us. So patient's right side is on our left and vice versa. And we can play with these images, and this is also contrast enhanced scan, and we can see that there is some kind of a tumor that is presses on the spinal cord and pushes spinal cord to the right side. So tumor develops from the left side, and it's dislocating the spinal cord to the right. From the examination of the patient, I know that there are no current signs or symptoms of the spinal cord damage, which allows me to think that this tumor has developed slowly and spinal cord has gradually adapted to this mass effect, and there are no current symptoms of the damage of the spinal cord. However, of course, if we allow this tumor to progress, the sooner or later damage of the spinal cord will happen, and patient will start experiencing symptoms. We can say at the moment patient is in very good position to have a surgery, because there is no spinal cord damage whatsoever to this point. So we can appreciate this structure is well bordered, it has smooth borders, it looks all the same, we can say it's homogeneous, which from radiological perspective, this is in line with meningioma. So meningioma, as its name says, is a tumor that originates from the meninges, and it's not exactly a spinal cord or brain tumor. However, it develops a mass effect, and it presses on the spinal cord, which can cause spinal cord damage, and this is the reason why we need to remove it. And we are going to do it tomorrow. So the surgery is done under general anesthetic. We will position patient in prone position, so lying on the belly. So we will need to fix patient's head in the clamps, in a rigid fixation, in flexed head position to have approach from the behind. We will do incision in the midline, in the cranio-spinal junction. We will approach spine from the both sides, and we will perform so-called laminotomy. So basically we will remove a lamina of C1 cervical body, and if necessary we will remove a lamina of C2 cervical body, and if necessary we will make some drilling also in the occiput to have enough space for a safe and comfortable approach to the tumor. After that we will open the meninges and we will remove the tumor as much as possible, aiming for the total removal. Of course, the most critical part of the surgery is to establish how well or bad the tumor is connected to the spinal cord. If it is very connected and have grown together with the spinal cord, if it has a common blood supply between tumor and spinal cord, we may not be able to remove tumor completely without causing any damage to the spinal cord, which is unacceptable in this case, as the consequences will be very severe. So we may need to leave some small part, a remnant of the tumor with the spinal cord, and remove just a vast majority of the tumor. But we hope that this will not be the case. If tumor is not connected very closely to the spinal cord, we may be able to remove it completely. After removal of the tumor, we will need to close the layers meninges in a watertight fashion and re-establish the laminas of C1 or C2 by performing a laminoplasty, and we will close the wound. So let's see how it goes tomorrow. Operation took nearly 4 hours. Okay, as you saw, surgery has been finished and actually it went very well. Complete removal of tumor was achieved, and the tumor was not too stuck to the spinal cord, so it was possible to remove it in a very safe manner. So we will see and we will see patient after she wakes up, and we will review how she is after the surgery.